Hello and welcome to the Dual Diagnosis module class. In this presentation, I will discuss how the diagnosis of a mental health disorder affects the lives of the people we support and how a dual diagnosis of a developmental disability and a mental health disorder set the stage for the programs and services our agency provides. The chapters contained in the Dual Diagnosis module book cover a variety of topics as they pertain to dual diagnosis, including various definitions, history and treatment models, common mental health disorders, mental health professionals and programs, services, understanding what we see, and treatment. We will begin with reviewing some common definitions. A developmental disability refers to a severe chronic disability of an individual that is attributed to a mental or physical impairment or a combination of a mental and physical impairment, is manifested before the age of 22, is likely to continue indefinitely, results in substantial functional limitation in 3 or more areas of major life activity, which include self-care, receptive and expressive language, learning, mobility, self-direction, capacity for independent living, and economic self-sufficiency. And lastly, a developmental disability reflects the individual's need for a combination and sequence of special, interdisciplinary, or generic services, individualized supports, or other forms of assistance that are of a lifelong or extended duration and are individually planned and coordinated. Intellectual disability falls under the umbrella of developmental disabilities. An intellectual disability is characterized by significant limitations in both intellectual functioning and adaptive behavior. Both intellectual and adaptive functioning are measured using standardized tests, with 100 considered as average. Scores less than 70 on both are required to meet the criteria, with adaptive behavior deficits below 70 in at least one of the 3 adaptive areas of social, practical, and conceptual skills. The disability must also have begun during the developmental period, which is before 18 years of age. There are 4 levels of intellectual disability: mild, moderate, severe, and profound. The level is determined by the level of adaptive behavior. Mental health refers to our emotional, psychological, and social well-being. It is all about how we think, feel, and behave. According to the World Health Organization, mental health is a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to his or her community. The World Health Organization emphasizes mental health is not just the absence of a mental health disorder. Mental health problems are severe disturbances in behavior, mood, thought processes, and/or relationships. The Diagnostic Manual of Mental Health Disorders, referred to as the DSM-5-TR, lists the different types of mental disorders. I will discuss the DSM-5-TR shortly. A mental health disorder, which can also be referred to as mental illness or a psychiatric disorder, is a mental or behavioral pattern that causes either suffering or an impaired ability to function in ordinary life. Dual diagnosis, or DD, refers to the coexistence of the symptoms of both intellectual and developmental disabilities and mental health problems. It is important to acknowledge that not all people diagnosed with an intellectual or developmental disability will be diagnosed with dual diagnosis, but dual diagnosis occurs more frequently in people with intellectual and developmental disabilities than mental illness in the general population. About 1/3 of people with disabilities served by state agencies nationally have both intellectual or developmental disabilities and mental illness. When providing services to people with dual diagnosis, the most preferred approach is the community-based model. The community-based model uses a team approach that focuses on the person's unique needs and abilities. The team works together to create a plan that includes what is important to the person and focuses on their abilities and desires, which is a person-centered approach. Program coordinators assist the team in finding services in the community that all work together, which is a collaboration among agencies. Likewise, in addition to program coordinators, a behavior analyst is an integral part of the team because their job is to collect and analyze behavioral patterns to better understand the function of the behavior. The collaboration among the team and other agencies is based on positive behavior supports. Before 1960, a common consensus among professionals was that people with intellectual or developmental disabilities could not have a mental health disorder. That stance resulted in inadequate treatment for people with a dual diagnosis. If any person diagnosed with a mental health disorder is left untreated, they cannot reach their full potential. Additionally, the person may have difficulty maintaining relationships with family and friends, may be unable to get a job or stay employed, will not be a generally healthy and stable person, may bring undue attention to oneself, causing others to avoid them and limiting opportunities for inclusion, will be affected further emotionally, may have an impaired ability to feel successful and accepted by others, and may be unable to plan for their future, have goals, and meet personal outcomes. When people experience hardships throughout their life, like trauma, loss, and any other unpleasant circumstances, the people may present behaviors that appear to be symptoms of mental illness, like depression, withdrawal, and sadness, among others. Single symptoms do not qualify as a diagnosis for a mental health disorder. A group of very specific behaviors must be present to warrant an assessment for a mental disorder. A psychiatric assessment typically involves 8 steps. A history must be obtained that includes social, psychological, past psychiatric, family, and medical information. The person's mental status must be evaluated, which includes observation of behavior, speech, emotions, and cognitive and perceptual processes. Psychological and neurological auxiliary data must be collected. A summary of findings must be established. A diagnosis is then rendered, followed by a prognosis and a biopsychosocial formulation, both conducted by a psychiatrist. And finally, a treatment plan is determined. The Diagnostic Statistical Manual, or DSM, is a tool used by mental health professionals to diagnose mental health disorders. The DSM was first authored by the American Psychiatric Association in 1952 and has been updated to many versions since then. The current version is the DSM-5-TR. Since the first publication of the DSM, the number of recognized mental health disorders has increased from 106 to 157. The DSM contains diagnosis criteria for 19 broad categories of mental health disorders. Only licensed professionals who are qualified to evaluate and diagnose mental health disorders are authorized to do so. They include psychiatrists, physicians, psychologists, clinical social workers, licensed counselors, neurologists, mental health nurse practitioners, and school psychologists. On the left is a page from the DSM, which shows diagnostic criteria for generalized anxiety disorder. With mental disorders, full patterns must be present to render a diagnosis. 1 or 2 symptoms is not enough. Observed behaviors may or may not be a symptom of a mental health disorder. For people with a dual diagnosis, healthcare providers must be careful to avoid diagnostic overshadowing, which is over-attributing a person's symptom to a particular disability. With diagnostic overshadowing, people with disabilities do not receive appropriate treatment for mental health disorders. There are many community services available to assist all people in North Dakota with mental health issues. Some employers offer employee assistance programs as a benefit to their employees. Community services include regional human service centers, regional psychosocial rehabilitation centers, local hospital mental health centers, the North Dakota State Hospital, and the Life Skills and Transition Center in Grafton. For people we support, the best service for them is determined by their team. The Life Skills and Transition Center is used only when all other alternatives have been exhausted. To review what I covered earlier, a psychiatric assessment typically involves 8 steps. One of the steps is observation and evaluation of a person's mental status, which includes their behavior. A behavior is an observable action that can be seen and described. Adaptive behaviors are behaviors that allow people to be independent. They are behaviors that allow people to navigate day-to-day living and are useful, functional, and necessary to survive and be happy. Examples are things like eating, walking, working, and sleeping. Maladaptive behaviors are behaviors that interfere with independence and get in the way of adaptive behaviors. They might allow the person to get what they want and need in the short term, but do not allow the person to get what they need in the long term. They are inappropriate responses to day-to-day living and prevent people from working, having friends, being happy, and succeeding. Maladaptive behaviors aren't necessarily an indication of a mental health disorder. The function of the behavior would need to be identified before it is determined to be a behavior that is used to help diagnose a mental health disorder. As we learned in the therapeutic responses class, all behavior has a purpose. Many times, using maladaptive behavior is the easiest and quickest way for people with intellectual and developmental disabilities to get what they need. Maladaptive behavior is not always a result of a person's disability or mental health disorder. When a person displays maladaptive behavior, a functional behavioral assessment should be conducted by the person-centered team to determine the purpose of the behavior. After a functional assessment is conducted, a behavior support plan can be used to teach replacement behaviors, which are adaptive behaviors. There are many causes of maladaptive behavior. It may be caused by a normal reaction to stress. There can also be medical causes. Examples would be if the person is experiencing pain, discomfort, or if they have seizures. Maladaptive behaviors can also be learned when the maladaptive behavior has been reinforced and the person doesn't know an appropriate adaptive behavior. Examples of learned maladaptive behavior might be a mom who buys candy in the grocery store checkout line for her crying child. The candy is the reinforcer, so the child will continue to cry when they are in the checkout line because they think they will get candy again. Another example is a child acting up in class who gets sent to the office. The reinforcer is they get to leave class. Behavioral phenotypes are another cause of maladaptive behavior. Behavior phenotypes are maladaptive behaviors that are symptoms of various syndromes or diagnoses. For example, people with Prader-Willi syndrome are obsessed with food, which often causes frustration when they cannot get food when they want it. The frustration can lead to maladaptive behaviors. The full range of mental health disorders that exists in the general population can also exist in people with intellectual disabilities, but the symptoms and patterns listed in the DSM might not apply to them. To serve as a tool in those instances, in 2007, the National Association for the Dually Diagnosed published the Diagnostic Manual, Intellectual Disabilities, a Clinical Guide. The manual serves as a guide for finding diagnostic equivalents that apply to people with disabilities. A diagnostic equivalent identifies the symptoms of a diagnosis as they would be observed and measured in a person with developmental disabilities. There are 19 total mental health disorders that are identified in the Diagnostic Statistical Manual. This module focuses on some, but not all of the 19 mental health disorders. They include personality disorders, which are classified into 3 groupings or clusters: anxiety disorders, psychotic disorders, mood disorders, and ADHD. Personality disorders are characterized by odd or eccentric behaviors. Cluster A of personality disorders consists of paranoid, schizoid, and schizotypal personality disorders. A person with paranoid personality disorder may show behaviors of an all-encompassing and unwarranted tendency to interpret the actions of people as deliberately demeaning or threatening. They may think people are out to get them and may also interpret innocent remarks from others as insults or threats. People with schizoid personality disorder may display a pattern of indifference to social relationships and a restricted range of emotional experience and expression. Features include minimal or no social relations, restricted expression of emotion, lack of warmth and tenderness, and indifference to others. Schizotypal personality disorder is characterized by acute discomfort in close relationships, distorted views and thoughts, and the person may be eccentric in appearance and behavior. They may also have extreme or odd beliefs. Schizotypal personality disorder may evolve into schizophrenia. Cluster B of personality disorders consists of histrionic, narcissistic, antisocial, and borderline personality disorders. A person with histrionic personality disorder may be attention-seeking and exhibit behaviors of pervasive extreme emotionality. They may be overdramatic and always call attention to themselves. People with narcissistic personality disorder believe that the world revolves around them. They may exhibit behaviors of pervasive grandiosity in fantasy or behavior, may have a lack of empathy, and may be hypersensitive to how others might view them. People with antisocial personality disorder may display a pattern of disrespect for and violation of the rights of others. They may attempt to prey on others' weaknesses through manipulation, exploitation, control, deception, and intimidation. A person with borderline personality disorder may display an instability of mood, interpersonal relationships, and self-image with marked impulsivity. Their interpersonal relations swing between suffocating dependency and mindless self-assertion. Cluster C of personality disorders consists of avoidant, dependent, and obsessive-compulsive personality disorders. A person with avoidant personality disorder may show behaviors of pervasive discomfort, fear of negative opinions by others, and timidity. They may be overly sensitive and constantly apologizing for fear of having hurt someone's feelings. People with dependent personality disorder may display pervasive, dependent, and submissive behavior related to the excessive need to be taken care of. They may be clingy and lack a real sense of individual identity. People with obsessive-compulsive personality disorder might have a preoccupation with orderliness, perfectionism, and control. They may insist that others submit to their way of doing things. Obsessive-compulsive personality disorder is not the same as obsessive-compulsive disorder, which is an anxiety disorder and very different from obsessive-compulsive personality disorder. Personality disorders are difficult to diagnose in people with disabilities for various reasons, and it's not because they don't have personalities. One reason is that a diagnosis requires subjective information about thoughts and emotions, which can be difficult to obtain from people with limited verbal ability. Additionally, a diagnosis relies on a person's experiences with relationships, and many people with disabilities haven't had close friends. And if they have had close relationships with others, they might lack the ability to understand they are being manipulated if it has occurred. Finally, some people with disabilities may have difficulty understanding abstract concepts like empathy or remorse. Another type of mental health disorder is anxiety disorder. I will discuss 4 areas of anxiety disorder, including generalized anxiety disorder, specific phobias, obsessive-compulsive disorder, and post-traumatic stress disorder. Generalized anxiety disorder is the most common anxiety disorder in the general population. People with generalized anxiety disorder anticipate and worry about future danger, whether real or unlikely, which can prevent the person from participating in everyday activities. Suffering is real and causes emotional distress. Common support tactics for people experiencing emotional distress as a result of generalized anxiety disorder include removing social and/or emotional expectations that are the source of the person's anxious behavior, giving clear, concrete, realistic, and achievable expectations, removing pressure and refraining from demanding performance that will be beyond the person's ability at this time of anxiety, slow down, and don't pressure the person to move or work faster. Never criticize the person's performance. Remind the person of times they were brave or handled a situation well, and use social stories to familiarize the person with a situation that is coming up. Phobias are another type of anxiety disorder. When someone has a phobia, they will experience extreme and unreasonable fear that occurs when a certain object or situation is present or expected. Common phobias fall into 5 general classes: blood injection injury, animals, natural environment like storms and water, situational like heights and elevators, and other phobias. To be classified as a phobia, the person must avoid the object, situation, or experience extreme distress when it cannot be avoided. The distress must interfere with routines, activities, functioning, or relationships. Poor coordination, poor motor control or balance, visual or other sensory impairments, abnormal muscle tone, skeletal deformities, obesity, or poor balance can all contribute to the development of phobias. Another anxiety disorder is obsessive compulsive disorder, sometimes referred to as OCD. People with OCD experience repeated obsessions and compulsions that are distressing and interfere with day-to-day functioning. Obsessions are unwanted, unfounded, and upsetting thoughts, images, or urges that are uncontrollable and unstoppable, while compulsions are deliberate physical or mental actions that are geared toward relieving worry and discomfort created by obsessions. Some examples of compulsions include insisting that all activities be completed at the same time each day, sniffing things, taking off and putting on clothes repeatedly, and arranging objects in a certain pattern. Post-traumatic stress disorder, or PTSD, is an anxiety disorder in which a person continues to re-experience a trauma from earlier in their life. People with PTSD will continue to experience trauma, will avoid anything that reminds them of the incident, and will experience nervousness and tension, which creates stress that affects their ability to lead a normal life. For people with dual diagnosis, the effects of PTSD may take other forms. They may exhibit fear, run away, or avoid certain people, places, or activities. They may become aggressive if they cannot escape from the situation that is causing the trauma. Part of the treatment plan for people with PTSD involves providing a quiet, relaxing, and safe environment for the person and getting to know them well. Some support tactics for people with PTSD include helping the person to feel safe, making activities predictable, helping the person establish relationships, building trust with the person, making home a relaxing place, helping the person establish healthy routines, helping the person set goals and make plans, helping the person to have fun, not forcing the person to revisit the incident, avoiding punishment strategies and restraints in behavior programs, teaching coping skills, helping the person rehearse how to respond to triggers, giving choices when problem behaviors occur, encouraging aerobic exercise, developing a support strategy for crises, limiting exposure to triggers, and getting to know the person and their story well. I will discuss only one psychotic disorder, which is schizophrenia spectrum disorder. Schizophrenia spectrum disorder is a disturbance that lasts at least 6 months and includes at least 1 month of active phase symptoms. People do not function with normal adaptive behavior and have difficulty achieving full developmental potential. Prognosis is usually poor. Hallucinations are the main recognizable characteristic of schizophrenia, and may occur in combination with delusions and illusions. Hallucinations are imagined sensations that seem frighteningly real and can take control of the person. A delusion is a belief that is reality-based and not a sensory misinterpretation like a hallucination. An illusion is when common objects appear bizarre or even life-threatening, like a piece of rope that seems to turn into a snake. With hallucinations, if no attempts at intervention or support are made, they last longer and are more severe. Support tactics for hallucinations include watching for signs of hallucinations and respond as early as possible. Talk to the person calmly and do not show fear or anxiety. Be a good listener. Your body language will be observed. Look and listen for messages in the person's nonverbal communication. Always remember to record what you observe. The more detailed description of the episode, the better. Record what the person did and said. Never leave a person alone if they are hallucinating. And lastly, get to know the person and become someone they can trust. Although there are a number of mood disorders, this module only focuses on 3, which are major depressive disorder, dysthymia, and bipolar mood disorder, or BMD. For a diagnosis of major depressive disorder, a person must display at least 5 of the criteria for depression during the same 2-week period and represent a change from previous functioning. The criteria for depression are depression itself, loss of energy, loss of pleasure and or diminished interest in activities, agitation or psychomotor slowness, changes in eating habits, appetite, or weight, thoughts of death or suicide, sleep disturbances like insomnia or hyperinsomnia, indecisiveness and poor concentration, negative thoughts, feelings of worthlessness or hopelessness, and inappropriate feelings of guilt. A person with symptoms of depression does not experience feelings of extreme happiness, joy, or euphoria. There are various support tactics for people who may be experiencing either bouts of depression or manic episodes. For someone who has diminished interest in things that they normally would, offer a variety of preferred activities and reinforce participation with positive statements, but do not require sustained involvement. Have a plan for taking a person home if they tire of an activity. After an initial refusal, wait and ask them again. For someone who is experiencing weight loss, prepare foods the person prefers and have them available throughout the day. Provide small amounts and reinforce efforts to eat. Make the eating environment pleasant. For someone who is experiencing insomnia, encourage a regular sleep schedule, but don't force the person to go to bed at a certain time. Help the person establish a bedtime ritual and limit naps. Reduce the intake of alcohol, nicotine, caffeine, and other stimulants. Encourage exercise, but not too late. And don't go to bed too early. For someone who is experiencing physical agitation, find constructive ways to use energy and allow the person an escape from activities that cause agitation. If someone is experiencing fatigue, plan brief activities and give the option to leave when tired. Adjust expectations to match their energy level and use gentle insistence. For someone who is experiencing feelings of worthlessness, point out their strengths, stay positive, and provide praises. Make frequent opportunities for the person to succeed. Avoid too many demands and gently help them to be more realistic if they express guilt over things that were out of their control or not their fault. For someone experiencing diminished ability to think, speak slowly, quietly, and offer one step at a time. Repeat concerns and provide limited number of options when giving choices. For someone who is experiencing weight gain, provide healthy snacks as substitutes for favorite foods and encourage exercise. And for someone experiencing thoughts of death, don't ignore or reinforce the behavior and seek advice. Treatment of a person with dual diagnosis can be challenging because of the difficulty conducting a thorough assessment and insufficient training of mental health professionals on working with dual diagnosis. However, If the team of a person with dual diagnosis decides to make a mental health referral to a mental health professional for that person, there are certain questions that need to be considered. Do the symptoms occur in most or all settings? Is there little change with medical or appropriate behavioral support? Have there been changes in sleep, appetite, or sexual function? Have hallucinations been observed? Have strong autonomic symptoms been observed in conjunction with hallucinations? And is the person in physical pain? Treating people with dual diagnosis involves collaboration between medical providers and members of the person-centered support team. A person-centered plan can outline the tools that both the medical profession and the person's team provide. The two models are different from one another, but collaboration of both can benefit the person overall. This table shows the differences between the two. With the medical model, disability is seen as something that could hold the person back, whereas with the person-centered model, disability is only a difference, like gender or race. Disability is seen as a personal problem with the medical model, whereas having a disability is neither good nor bad with the person-centered model. It is just a part of who the person is. With the medical model, the person needs a cure or something to make them less disabled, whereas with the person-centered model, problems come from a person with a disability trying to function in an inaccessible society. With the medical model, only professionals can help the person fit in and be made better. With a person-centered model, the person, an advocate, or someone who wants to help can make the changes that are needed. Once a person's team is established, they work together to ensure effective service is provided to the person supported and that focus is placed on an improved quality of life for the person and their family. The team may consist of the person supported, DSPs, a mental health professional, family members, a program coordinator, and a behavior analyst. Before the team determines the best treatment options for the person supported, an assessment must be conducted to collect baseline data, which is initial data that future data can be compared to. Baseline data helps the psychiatrist in making a diagnosis and measuring progress. For the general population, treatment of mental health disorders typically involves psychotherapy, medication, and peer support groups. Medications can be effective for improving symptoms to promote recovery, but they do not cure mental health disorders. Medications are the primary method of treatment for people with dual diagnosis. When a person supported has a medication change for a mental health disorder, DSPs are responsible for observing and documenting behavior changes, for knowing the purpose of the medication, and for observing and documenting side effects. Sometimes side effects of a medication used to treat non-mental health disorders can alleviate some mental health disorder symptoms. For example, the medication valproate is used to treat epilepsy, but can also be effective in treating bipolar disorder. Before the 1960s, many professionals believed that people with intellectual and developmental disabilities could not suffer from mental health disorders, which is why treatment for mental health disorders in people with dual diagnosis is fairly recent. Because of that reason, medication treatment for people with disabilities has been over or misused. In order to avoid medication misuse as a chemical restraint, regulations regarding medication treatment were established. The regulation requirements include that active treatment and a behavior support plan must accompany any use of a psychotropic drug used to control behavior. Also, the team must attempt drug reduction along with the advice of a physician. Additionally, the team must monitor side effects of the drug. Finally, teams must know and define the targeted behaviors specifically. Cognitive behavioral therapy is an additional treatment for mental health disorders. Cognitive behavioral therapy examines how a person's thoughts, feelings, and behavior can get stuck in unhelpful patterns. The person and the therapist work together to develop new ways of thinking and acting. Cognitive behavioral therapy assumes that all people have an intrinsic meaning to their behavior and that self-determination can be fostered through therapy. Cognitive behavioral therapy might not work for people with intellectual and developmental disabilities because their lack of life experiences limits their ability to communicate feelings and understanding relationships. They may also lack communication skills and be incapable of understanding consequences of their behavior or how their behavior affects others. Thank you for viewing the Dual Diagnosis module presentation. The information covered in this presentation provides insight which will enhance the work that you do with the people we support. When you are ready to take the test, please contact the trainers to set up a test appointment. Also, please feel free to reach out to the trainers with any questions you may have. The information contained in this presentation was provided by the authors of and derived from the module book Dual Diagnosis 1, Intellectual Disabilities and Mental Health Disorders.